Today's case is titled Ophthalmic Manifestations in Children with Type 1 Glycosylation Disorder, a case report. So, congenital disorders of glycosylation are a group of inherited metabolic diseases caused by defects in glycosylation pathway, leading to multi-system involvement. Clinical manifestations include developmental delay, intellectual disability, hypotonia, hypoglycemia, hypothyroidism, adrenal insufficiency, protein-losing enteropathy, chronic diarrhea, and failure to thrive. Esotropia linked to underlying neuromuscular dysfunction affecting eye movement, optic atrophy which can lead to visual impairment, retinal dystrophy, ptosis, refractive errors. Our case is a 9-year-old male known case of type 1 glycosylation disorder, came to our setup with for ophthalmological evaluation. Past history: at 5 months of age the parents noticed child was not feeding properly with frequent regurgitation. He was unable to gain weight appropriate for his age, inward deviation of right eye at 1 year of age. Gross motor and language milestones were delayed, hypotonia was present, MRI brain was done as suggested by the pediatrician, which suggested a prominent cisterna magna, hypoplastic inferior vermis suggestive of Dandy-Walker variant. Transferrin isoelectric focusing elevated acylotransferrin and diacylotransferrin, and low tetracylotransferrin was present. On ocular examination, visual acuity was 636 and 618. Cornea conjunctiva pupil was WNL, anterior chambers was within normal limit, fundus was also within normal limits. We did retinoscopy under homide, which revealed a refractive error of 0.75 and 0.5 spherical, with -1 cylinder in each of the eyes, best correcting to 618 and 612. In orthoptic evaluation, there was primary ocular deviation, right esotropia 20 degrees. The angle of strabismus showed deviation of 40% diopters of esotropia in primary gaze. No ptosis was seen. There was abduction deficit in each of the eyes. In this case, the patient presented with alternate convergent squint, deficient abduction, and significant refractive error. The presence of abduction deficits without evidence of cranial nerve palsy suggests a broader neuromuscular impairment associated with PMM2 CDG disorders. The absence of optic atrophy at this stage does not preclude its potential development in the future, highlighting a need for long-term ophthalmic evaluation and surveillance. The normal anterior segment examination in this patient further suggests that the primary deficit lie in the neuromuscular function rather than structural abnormalities. Ophthalmic signs like esotropia, abduction deficits, refractive error may be early indicators of CDG. These manifestations reflect underlying neuromuscular dysfunction rather than primary structural issues. Early ophthalmic evaluation is essential for timely diagnosis and management. Regular eye checkups can prevent amblyopia and long-term visual impairment. Infantile esotropia with abduction deficit with amblyopia with hypotonia is not an uncommon finding in rare congenital glycosylation disorder, and children diagnosed with these conditions should undergo thorough ophthalmic evaluation as early as possible.
Why do you call the category of CDG?
So there was the gene mapping was already done by the gynecologist and the pediatrician, and we had the report on presentation.
Why do you correlate the alternating esotropia or esotropia with this CDG?
It has been found in the earlier studies as well that the
But
children.
there were other things also apart from this optic nerve, optic atrophy
Yes.
and ptosis and
Yes, sir.
other findings.
Yes.
Only esotropia is there. On the basis of that, how would you call it that it comes in the category of CDG?
It was like we had the report and then we found these symptoms and signs present.